Can't make this any better.
So this is the presentation we got. I just copy pasted directly what Dr. Cohen sent me. So we have a 60-year-old female, gradual decline in vision, both eyes, been coming on for 10 to 20 years. She notices blind spots and been seen at the Eye Institute before, and we're seeing her here now. The only medical history is hidradenitis suppurativa, some hypertension. Other than that, you see her systemic meds, a lot of vitamins and supplements. Vision 20/80 pinholes to 20/50, and then 20/63 pinholes to 20/50. Pressures were both normal. And here we go.
You have a color fundus photo of the right eye. The vitreous appears clear. The nerve appears like it has sharp borders. The vessels seem to be pretty within normal limits. Don't seem to be too attenuated or tortuous. An attention is drawn to the macula. There do seem to be some pigmentation around the fovea, so maybe areas of lighter pigmentation surrounding the central fovea as well.
Great. Now I'll give you the other eye, and then there's a more detailed photo coming.
So this is the color fundus photo of the left eye. Again, looks largely similar. The vitreous appears clear, nerves appear good. Maybe a slight more tortuosity to the vessels, but appears within normal limits. And then I think less so around the macular region. There's some lighter spots around the fovea.
Yeah, perfect. And here's that more detailed of the right eye, and as well as the left eye.
Yeah, these are multicolor pictures. So the other one was a color, this is a multicolor. The multicolor in this particular diagnosis is pretty good. Go back to the first one. The first one's kind of nicer.
Right.
What do you see there?
So I don't recall David's lecture, but there is some.
It should look pretty normal. I mean, it should look kind of hard. It look a little green is okay, but that center is not as normal as it should be.
Okay.
So just pretend it's a color, and what would you say? What's there?
If it's a color?
Yeah, pretend like it's a color picture and tell me what you're seeing. You're supposed to, it's sort of colory.
Maybe some like speckled spots around the fovea, but it looks to be largely normal to me.
Well, compared to normal, it's kind of a ring. It's like a donut in the middle.
Oh, okay.
So normal multicolors don't have that ring. So
The
it's a
ring
little,
surrounding the foveal area?
yeah, center of the
Okay.
And that one's not as obvious. And then there's that cotton wool spot. I don't know what that's from. Is the patient diabetic? I think maybe.
Not diabetic, but has high blood pressure. That's all.
Okay, yeah, ignore that. That's not as much as it's probably a problem.
And so this is a autofluorescence
Good,
of
perfect.
the right eye. There seem to be areas of hyper autofluorescence around the fovea, as
Good.
well as hypo, I think, within that area as well.
And where's the where's its nasal, temporal, superior, inferior? Where's the hyperautofluorescence compared to the center of the fovea?
More temporal.
More temporal, good. And then show the other one.
Oh, yeah.
Good.
This appears to kind of depict the same thing, a little bit more temporal hyperautofluorescence.
Good. Now, you guys are young, but for the older people, the two of you, what's when you see a normal autofluorescence, what do you normally see in the middle? Hypo. Yeah, and what's that from?
Sorry.
In the very center. What's in the very center of your macula? The what? The pit, but they would block autofluorescence. Gran or macular. What's that?
like the outer retina that normally would be blocking it.
Yeah, but what's there? What's the thing? What's the, I'm trying not to
Barnard.
use a word. In the center of the macula. If you look at someone's macula, it's not all the same color. The center of the macula is a little darker. And on autofluorescence, it's like particularly dark. Some of it's the RP is a little, it's true, the RP is a little denser in the center of the macula, but that won't block autofluorescence because
Right.
it's autofluorescing. So there's another thing that's dark in the center of the macula that can affect all your imaging. Bryan or Madeline, you want to chime in?
Is it Henley's layer?
Yeah, not really. It's the pigment. So it's hard because it's not here. So it's always hard to like, you have to all the normals in your head, which you guys don't have yet. But if you don't show a normal autofluorescence in the presentation, maybe I'll show you one later, but we'll see one today probably. But the normal autofluorescence has a big dark spot in the middle, and that's the macular pigment. In this particular disease, it's like almost totally missing. I mean, it's remarkable. The patient's vision is not that bad, right? I think their vision's not horrible,
No,
isn't it?
yeah, it was like 2080, 2060,
Yeah.
to 2050.
There's no there's really, I mean, that's almost no macular pigment in the left eye. And the right eye was the same thing. So there's the hyperautofluorescence, but there also centrally, there's the absence. It's always hard to say the absence of a finding if you don't know all the normals. So I think in this disease, the autofluorescence is very helpful. All right, sorry, go ahead to get that out.
All right, and moving on, you have your, go ahead.
So this is an OCT MAC of the right eye, horizontal OCT MAC of the right eye. It appears that there is disruption of some of the outer layers. I think the ISOS junction around the fovea is missing. There seems to be some like atrophy, disorganization of the layers, and then maybe some like this.
That's perfect, that's very good. Is the retina itself thickened? Is the whole retina, if you look at if you ignore the architecture, is that pattern about the right thickness?
I would say so.
Yeah, it's pretty close. So there's not really thickening, it's just the architecture's all messed up. Good. And then the left eye?
Oh, so is this like a vertical?
No, it's the other eye. It's the left eye. Horizontal,
Horizontal.
I think, hold on, actually, that's the same eye.
Maybe here.
No, I think you're right. That's
That's left eye.
Did I give you 4 scans or 2?
You gave me 4. You gave me
Okay,
2
so these are 2
verticals
to the right, 2 to the left. Okay, so this is horizontal vertical to the right, and then the next 2 should be horizontal vertical to the left.
Okay, so this is the other eye you haven't seen yet.
Okay,
So the other eye, I think less severe disease presentation, but largely similar. There is some disruption of the ISOS junction around the fovea, some intraretinal cysts right there as well. The retinal layers otherwise appear to be kind of well organized elsewhere, not thickened.
Perfect. And
so those 2 are the left eye. The first 2 are the right, the last 2 are the left.
there you go. Sorry about that for the confusion. So now you have your left eye and then your other left.
Okay, that's good. Is there anything else? Did we do fluorescein? No, sorry, no fluorescein.
Those are the only photos I have. I'll include some later in the slides, but moving on to the differentials, anything come to mind, and then I can list out some that I put on here.
I know she's only 60. I don't really see drusen, but maybe like an earlier presentation of macular degeneration with some atrophy, hypertensive retinopathy, diabetic retinopathy.
Okay, that's good. Anybody else want to add anything from the 4 of you? Just take it, leave it with first years. Okay, it's symmetric. I mean, when something's symmetric, you can always throw dystrophy in there. You know, say macular. If it's the same in both eyes, say, oh, it could be a macular dystrophy. And then there's the diagnosis. So go ahead, what's your differential?
I'll toss up. Yeah, so these were just a handful that I put up here. Coats, MAC holes. You said DME already. Crystalline retinopathy, IGFT type 1 or 2. Yeah, here you go. Anyway, so moving on to the diagnosis, or I'll give you the summary slide real quick.
Yeah, it's nice to talk about.
I didn't want to give up the summary slide first because, you know, some of the signs and buzzwords may have been given it away. But you can see here, vitreous disc all looks fine. Vessels, you couldn't really appreciate it on this patient, but you can get mildly dilated right angled venules and capillaries around the fovea. You saw in the macula that temporal parafoveal graying and subtle loss of that transparency. And then occasionally you can see some crystalline deposits. Periphery all looked fine. In the fundus autofluorescence, you saw that temporal hyperautofluorescence around the foveal center. Let's see. And then in areas of increased pigmentation and RPE hyperplasia, you can have hypofluorescent spots on the fundus autofluorescence. And OCT MAC, you saw that focal discontinuity or disruption of the ellipsoid zone, loss of outer retinal layers, and disorganization of inner retinal layers. So you have that outer retinal subsidence, and you know you have that sinking of the retina towards the RPE, and then you have these cysts. They weren't super prominent, but you have cavitation-like cysts that can encompass all retinal layers, and they're more like structural void spaces rather than fluid-filled cystic, without leakage on FA. And then I don't know, it was a very subtle, but on the OCT you could see a couple hypertransmission defects as well.
Nice, thanks.
So the disease is MacTel type 2 specifically. It's a bilateral condition characterized by ectatic capillaries, the macula, atrophy of the neurosensory retina. And so you have that characteristic decreased retinal transparency, known as retinal graying. And then, like I said, these crystalline deposits, you can have cavitation-like changes that can develop into full thickness macular holes, like Dr. Cohen mentioned in a few patients. And you can get subretinal neovascularization. When all the layers have atrophied away and you just have the ILM remaining, you can have a characteristic ILM draping. I just separated in type 1, type 2. Type 1 is more congenital, unilateral. It's also known as aneurysmal telangiectasia. It's more common in males and females and more in young. So it's like a young male unilateral presentation. You can also see cercinate exudate, and it's thought to be similar or a possible variant of Coates, and it's very uncommon. Whereas type 2, the one that we see here, it's acquired and bilateral. It's also known as juxtafoveal telangiectasia. It's the more of the common subtypes. There is a subtype 3, but it's kind of fallen out of, I don't know, maybe not. From what I read, it's not really, we don't look much into it anymore.
Oh yeah, three's from Gass's textbook, and there's a question whether it exists. I thought I saw it once. I've never seen it.
Yeah, so I left it out. It may be in the
It's supposed to be
BCSD.
familial. It's a weird one.
Yeah, but anyway, type 2, what we're kind of paying attention to now, it's about similar in males, females, onsets 40s to 60s, and a very strong association with diabetes, hypertension. And the main complication is that subretinal neovascularization and more advanced. Let's see. You can also get hyperplastic plaques of the RPE found at the end of the dilated vessels, and it can be associated with absolute scotomas. And then, like I said, the neovascularization originates from the deep capillary plexus, but may invade the subretinal space.
And those plaques look a lot like bone spicules. So it's almost, and I think it's the same pathophysiology. Anytime you lose your outer retina, you can get those old bone spicules because the vessels touch the RP and then you get this pigment migration, probably. So
yeah, I think I may include some photos later.
Okay, yeah, it almost looks like foveal bone spicules.
Anything else you want to add to that, or that was just kind of an overview? All right. Its etiology, like I said, it's found there's a prevalence of diabetes and hypertension in a lot of these patients. Suggests a high prevalence of, it points towards like a vasculopathy sort of picture. These changes are associated with disruption of outer nuclear layer, ellipsoid zone, and then can lead to pseudolamellar holes and RPE hyperplasia and migration into the inner retinal layers. Let's see. So some of the things here, there's not a really strong, that we haven't already talked about, not a strong genetic association. However, in some cases of monozygotic twins in some of these studies, they've seen it in twins, so suggesting a potential genetic component. And then we'll talk about it more, but the prevention and management, there's no real proven prevention. There's some trials and different things, and a paper that Dr. Cohen shared with me that I'll talk about too, of some of the things we're looking into. But the main thing is controlling hypertension and the diabetes due to its higher prevalence in MacTel Type patients. The main symptoms that patients will complain of is decreased vision, like a binasal scotoma bilaterally, and that's because of the area of atrophy there, temporal to the macula. And then, like I said, the treatment, there's not much. Anti-VEGF has a place for patients that have developed that subretinal neovascularization in later stages, and then also found that smoking may be a good modifiable risk factor. The pathology is that the macular cell, the primary degeneration sites is those parafoveal neural abnormalities in the macular cells rather than the retinal capillaries themselves. So you see disruption on histopathology, you see disruption of pericytes, ectatic vessels, and dilated venules that dive deep into the deeper retinal layers, giving that right angle appearance, and evidence of RPE hyperplasia along them, forming those plaques. And you see vascular occlusion, inflammatory changes that can lead to loss of the layers, outer nuclear layer, ellipsoid zone, and later forming these cystic cavitations that can encompass all the retinal layers, leaving that ILM drape. And so the diagnosis is made by clinical exam and mainly by imaging. The symptoms can help, but there's no real lab test out there. So like I said, the main complaint is binasal scotomas due to the involvement of the temporal paracentral macula. Vision is generally not super bad. The vision is rarely reaches legal blindness. 50% keep 20/32 or better vision according to the MacTel project. And then vision decrease can most commonly be because of development of Mac hole or SRNV. So I'm going to go into imaging because that's kind of the most important, it seems like, for this, just in diagnosing it. So at color fundus photo, you lose the retinal transparency of that parafoveal graying. You see crystals, right angle venules, and telangiectatic vessels on fundus. Fundus autofluorescence, you have increased foveal hyperautofluorescence, secondary to loss of the pigment. OCT, you see that cavitation like cystic cavities, and you can have that ILM drape. I'll show you pictures of all these. OCTA has become important. You can see foveal avascular zone enlargement in a distinct irregular shape, retinal capillary non-perfusion, and then FA. You see leakage in later frames. So here, these are some of those characteristic signs I've mentioned. This is a picture with that green arrow showing that kind of right angle diving of the venules. And then you see that ILM drape on the bottom photo, and then that subsidence of the retina, loss of the outer nuclear layer as you see it sinking towards the RPE on the OCT there on the right. Here's just some more photos I found of it, of those crystal kind of deposits as well, and then that temporal parafoveal graying. This is FA, just showing some late leakage. So there's been some proposed staging. And these are kind of the 5 stages that have been proposed in some of the literature, with stage 1, normal fundus with very subtle changes on fundus autofluorescence. Stage 2, you start to get that graying effect, and then hyperautofluorescence. You have those crystalline deposits right at the sub-ILM that can be present. Stage 3, you get moderate I can never say that, changes, right angle venules, and capillary remodeling in the outer retinal layers. Stage 4, you start to get the pigmentary changes with RPE migration and hyperplasia. And then stage 5, you can get presence of retinochoroidal anastomosis and with exudation and hemorrhage. So the main complications, like I said, is subretinal neovascularization, as well as those plaques of pigment. And those generally follow photoreceptor loss and associated with absolute scotomas. So the management is, anti-VEGF if there is subretinal neovascularization. There's no proven treatments. There has been some trials that are in, there's currently in phase 3 clinical trials of a ciliary neurotrophic growth factor that has shown in animal models has been effective in slowing vision loss from that photoreceptor cell death. And so we're eagerly awaiting. It's basically an intraocular implant where they load these human RPE cells transfected with an overexpression of that CNTF gene, and then it's loaded and delivered into the vitreous cavity, and it's supposed to help support the slow that photoreceptor cell death. Prognosis is pretty good. Type 2 patients, they generally have visual acuity of around 20/40 in more than 60% of the patients. Rarely leads to 2200 or worse vision. And in patients, about 80% of the eyes with neovascularization or MAC holes, the vision still remains better than 2200. In the eyes with visual acuity less than 2200, there's advanced disease, or generally with pigmentary plaques present. And so this was a paper that Dr. Cohen shared with me. Thought that it was pretty interesting. It talks about the relationship that they saw in studies of patients with peripheral neuropathy as well as MacTel 2, and the levels of serine that were observed. And researchers have identified that low levels of amino acid serine can lead to accumulation of toxic lipids called deoxysphingolipids, and they're thought to damage the neurons. So this lipid buildup can kind of advance the process is kind of what we're thinking. And so it's kind of starting to guide maybe, looking for treatments that can focus around that. There's also researchers that have observed that using fenofibrate, a lipid-lowering drug, might reduce this deoxysphingolipid accumulation and toxicity. So just continuing to study the disease, see kind of relationships with that, and see if there's anything to do to develop treatments out there. Here's my references and just a couple of pictures if there's any questions.
Perfect. That was very good. Nice presentation. Any questions on MacTel? I love that. When we first got the OCT scanners, I pulled all my MacTel patients in for scans because it's sort of an enigmatic disease. This was 2001, I think. And I found the findings. So I actually wrote a paper on this a while ago, which was held up, but anyway, that's a whole nother story. But anyway, I think it's interesting. And we still don't know that, we still don't understand it. I put my MacTel patients on serine because of that paper. So I take a little serine. And one of my patients said it helps him sleep. I don't know, my sleep patterns are not normal. So I take that. But anyway, great presentation. And remember those autofluorescence images. We'll show another case, I'm sure, we'll have an autofluorescence, where you can see the difference. All right, great job, Bryan. Thanks for all that work.